All right, guys, I'd like to welcome everybody to the first Orthopedic Associates Internet Zoom video conference. Tonight, we have the pleasure of talking with you guys about arthritis and diabetes, a little bit about both separately and how they are interrelated. My name is Dr. Russell Tigges. I'm an orthopedic surgeon at Orthopedic Associates. I'm here along with Dr. Karl Ziermann. Karl, see if he can turn his camera back on.
How are you today?
There we go. Karl's a doctor at the Orthopedic Associate. Well, I'll let him give his ramble about what he does in a bit. Just a few things to share with you. Number one, this is our first video conference, so bear with us. We're going to have a couple, hopefully small pebbles in the road. Nothing too bad, but we're going to try and work through this. Number two, if you are doing this on a computer or anywhere really, there is a chat box. And at any time during this lecture or conference, you're welcome to type a question in the chat box. We are going to try and read them. We're going to try and answer them during the talk. We're definitely going to try and do that after the talk. We're also going to open the mics up after we're done talking and let people ask questions. The best way to do that is probably when we're done. There is a little thing at the bottom of your screen where you can raise your hand, and we'll unmute the people who raise their hand, and they're welcome to ask some questions, and we'll give the best answers we can. So without further ado, I'm going to start this off with a little kind of rundown of osteoarthritis. First slide. All right, like I said, osteoarthritis and diabetes. I specialize in hip and knee replacements. Dr. Ziermann deals with all types of arthritic conditions and medical conditions. And next slide. So osteoarthritis, you know, a lot of people always ask, what is osteoarthritis? Well, simply put, osteoarthritis is the loss of cartilage or the loss of cushioning in your joints. Why do we get it? Well, that's the billion-dollar question these days. We really don't know. There's some obvious reasons like injuries. There's autoimmune arthritis like rheumatoid arthritis or lupus. But good old-fashioned osteoarthritis, we have no clue what causes it. Some theories are that it's a virus. That's a hot little topic these days. It's not really just plain old wear and tear. It can come from malalignment, which can lead to loss of the cartilage. But just because you're 110 years old doesn't mean you get arthritis, even if you've been very active. So who does get osteoarthritis? Well, like I said, people who have injuries, we do think that there's a very large genetic component to it. Especially in hips. It's very rare to see someone come in with bad hips if their parents, or at least one of their parents or some relative, didn't have hip arthritis. Knee arthritis, we see a lot of people who were born with bow legs. That predisposes you to arthritis because it's an abnormal angle to wear out your knees at. Multiple injuries to the knees can also lead to arthritis. We call that post-traumatic arthritis because it happens after trauma. Who else gets it? You can get it. I've never seen a joint replacement that's needed from Lyme disease. Although there is Lyme arthritis, that just means there's inflammation in the joint for that. Next slide. So just a couple, I think, really cool pictures. The picture on our left is a picture of a knee. You can see the thigh bone on top and the shin bone underneath. And look at that space between the two bones. Now that space is not your meniscus, as some people might think it is. That's actually the cartilage that covers your bones. And that cartilage is the cartilage that gets worn away as you develop arthritis. The picture in the middle, perfect example of knee arthritis. This is where we get the term bone-on-bone arthritis. You can see that cartilage space is completely gone and we are rubbing bone on bone. That's severe arthritis. The picture on the right is a hip. You see the ball joint right there. You can barely see the joint because on the top there, it's rubbing bone on bone. The space between the ball and the cup is completely gone on one part and it's partially gone on the other. So those are good examples of what arthritis looks like on x-rays. Next slide. So of course for me, eventually what you end up seeing me for are joint replacements, hip replacements, knee replacements, partial knee replacements, shoulder replacements. We're going to talk a little bit more about those down the road here. Next slide. But first we're going to have Dr. Ziermann jump in and kind of give us an overview of diabetes.
Thank you very much, Russell. So as you said, my name is Dr. Karl Ziermann. I am internal medicine and sports medicine, orthopedics. That's kind of where my specialty comes from. So I'm going to talk to you a little bit about diabetes and how this can play a role in arthritis and modify some of the treatments. So broadly, there's a couple types of diabetes, a little bit more than just type 1 and type 2. But as you see, type 1 is more autoimmune. That's typical, the kind of juvenile diabetes that many of us may be familiar with. This person needs insulin. They have to have insulin given to them because they have no insulin or insufficient insulin for them. Type 2 diabetes is a little bit more complex. Sometimes it's inadequate insulin. Sometimes it's insulin resistance. Sometimes it's beta cell destruction, which is what produces the insulin. This is often associated with being older. It is often associated with some genetics as well, including as well as some obesity as well. There's some other causes of diabetes as well. These monogenic and type 1.5, which is a little bit of both, maybe pancreatic disease, infection, which can damage the pancreas, which can set up for diabetes. Next slide, please. So there's 4 ways to diagnose diabetes. Broadly, it's fasting blood sugar, which is usually over 126, a random blood sugar over 200 with symptoms of hyperglycemia. Symptoms of hyperglycemia would be including things like going to the bathroom a lot, polyuria, drinking a lot of fluid, being very thirsty, so polydipsia. Sometimes weight loss, you actually can urinate out a lot of sugar. So sometimes when diabetics get diagnosed, they often actually losing weight because they're actually urinating out a lot of that sugar. Fatigue, going to the bathroom at night can also be causes of diabetes. Repeated testing is often indicated to help diagnose as well. We don't do this, the third one as much, the 2-hour blood sugar postprandial, or you drink a high sugar drink and then you check your sugar for several hours. We don't do that as often, but that is used in certain situations. And then the A1C is a very common way that's being used right now. Has a couple challenges with it in terms of hemoglobin amount and anemia and things like that, but it is a very good test of the average of your blood sugar for 3 months. So 6.5% is the blood sugar. So saying it's around 100, 150, 180 blood sugar for the last 3 months. That can be falsely good with a lot of variation. So if you have a lot of lows and some highs, and they balance out and they can kind of average out to be not too bad, but that up and down in the blood sugar can be very damaging to blood vessels, to kidneys, to heart, and it causes a lot of inflammation, which is what sometimes can be associated, can aggravate some of the arthritis. Fructosamine is just a little bit of a newer way. It's a last 2-week version of blood sugar. Not used as often, but it's just there as a potential useful tool to help diagnose or manage diabetes as well. Next slide, please. So these are some of the complications of diabetes. This is, unfortunately, diabetes affects pretty much the whole body. It can affect the eyes. It's a very common cause of blindness. It can affect the kidneys, high blood pressure, kidney failure, dialysis, very common cause of kidney disease, neuropathy, some of the things that we see in the office, nerve pain, lower extremity, burning in the legs, numbness in the hands and feet, non-healing wounds in the legs, ulcers, peripheral vascular disease, of course, heart disease. One of the leading causes or contributors to heart disease is diabetes. And then, of course, strokes, cerebral vascular disease, transient ischemic attacks, all common complications related to diabetes, particularly when it's not managed appropriately, early, and aggressively. Next slide, please. So the treatment for diabetes, treatment fundamentally really starts on diet. Whether you're type 1 or type 2, you cannot manage diabetes well without having a good, healthy, balanced diet. Carbohydrates is the main problem potentially in diabetes in terms of particularly what we call high glycemic foods, or foods that cause a lot of blood sugar response, a very high blood sugar response. Things like bread, rice, pasta, cookies, cakes, pastries, soda, juice, sweet tea. I worked in North Carolina for a little while, so they love their sweet tea down there. So adding in things like moderate to high protein diets, good fats. Fat has, for years, fat was thought to be the enemy. Fat is not as bad as as we were told over the years. Fish oil, good healthy fats such as nuts, seeds, some legumes, avocados, olive oil, excellent sources of fat, and it can really actually be quite helpful in diet, particularly when you're cutting back on the carbohydrates. Exercise, being active, both from the osteoarthritis and the diabetes, that active lifestyle is so important to help burn through sugar, help keep muscle strength, and help allow it can help reduce some of the effects of diabetes, and in some cases, really significantly prevent diabetes. And there's so many different exercises you can do. I'm going to get into some of those in a few minutes, but really any activity to really help, again, keep that sugar down and keep that diabetes away. These are some medications. The medications in diabetes have really evolved over the last few years. Metformin is one of the oldest medications, pretty standard for treatment of diabetes. But the GLP-1 agonist, or Bydureon, Byetta, there's a number of them in that group. And the SGLT2 inhibitors are really the big drugs now for type 2 diabetes. They have had wonderful studies on them in terms of positive effects on weight loss, effects on the diabetes, obviously, reducing what we call major coronary events, so MACE, so major adverse coronary events. Both of those drugs do have a positive effect on the heart as well as diabetes. The SGLT2 inhibitors also can prevent kidney disease in diabetes as well. They really, have been kind of game-changing drugs for diabetics. Some challenge with expense and things like that, but those are the kind of go-to drugs if we need to do medications. Sulfonylureas, the glipizide, glyburide, TZD or Actos. Those are older medications, have a fair amount of negatives, but they are very inexpensive. So sometimes from a cost perspective, they're the choices that we need to do. And of course, insulin. Next slide, please. Next slide. We can move this slide, Dave. Sorry. There we go. Thank you. So weight matters, in association with both the diabetes and the osteoarthritis. Obesity is a major risk factor for arthritis. Overweight women have a 4 times greater risk of osteoarthritis. Overweight men are 5 times greater risk of arthritis. Multiple studies have shown these numbers, but losing 1 pound of weight takes 4 pounds of pressure from your knee. So you can see if you're 20, 30, 40 pounds overweight, that could be profound in terms of its positive benefit for you with respect to your arthritis, particularly for the knees and the hips with the weight-bearing joints. Next slide, please. Even just 10% of weight loss can improve symptoms. So, we don't always necessarily look to try to get people to that perfect ideal body weight. That's not what this is always about. Even just small benefits, small positives in terms of weight loss can really make significant improvement. Studies have shown 20% of weight loss can cause less pain and improve their distance to be able to walk in this special test called a 6-minute walk test. It can reduce inflammation in the knees as well. Again, reducing that osteoarthritis. Next slide, please. So, the next couple slides just kind of go some basics in terms of how we look to measure body weight. Ideal body weight is 50 kilograms plus 2.3 kilograms for every inch over 5 feet. Body mass index, which is a calculation of weight in pounds divided by inches. Waist circumference, body fat measurement. The triangle is all different ways that we look at body skin fold thickness, bioelectrical impedance, DEXA scan, things like that. All different ways to kind of look at body weight in terms of calculating muscle mass versus fat-free mass or fat mass. Next slide, please. This is just a little graph showing the BMI. When you talk about what does overweight mean? Well, if you look, overweight is anything greater than a BMI of 25. And then there's studies that show 30% of people are obese, and even up to 50% of people can be deemed overweight. Now, the BMI has some challenges with muscle mass and things, but that overweight is not as high as you think it is. So 25 is the cutoff for that. And if you look at the bottom, a BMI greater than 40, which would be class 3 obesity, morbid obesity, that could really be challenging from a hip replacement and knee replacement. It may be contraindicated, and some insurance companies may even have not approved that replacement until we get that BMI under. So it's really important to kind of focus on this early to really help get your symptoms under control and prevent some of the things that may need to be done down the road. Next slide, please. These are some different complications from diabetes. Some of them, if you notice, are very comparable to what was already there: the coronary artery disease, some of the brain issues related to diabetes, but also, obesity will affect lung disease. It's been in a paper a little bit recently with the COVID-19, but sleep apnea, what we call hypoventilation syndrome, fatty liver, gallbladder disease. It can affect menstrual period in younger women. Obviously, arthritis, as we talked about, the skin, even cancer risk goes up with obesity. So it's really important to help manage this as soon as possible. Next slide, please. So diabetes and osteoarthritis, again, high blood sugar increases inflammation. Diabetes is associated with obesity, and we talked about how the obesity, the weight, any significant increase in weight can have a significant negative effect on the bones, on the joints. Blood sugars are contingent on several factors: exercise, carbohydrate intake, particularly the type of carbohydrates and the quantity, insulin levels, sensitivity hormones, different drugs, different hormone levels, testosterone, estrogen, things like that, all play contributing roles into how blood sugar may be utilized, and muscle mass and things of that nature. And the goals of therapy are to obviously decrease blood sugars in a safe, effective manner to keep it at a level around 60 to 90, which is a generally speaking, the kind of recommended level that we want to keep the blood sugar at. It does become a perpetuating problem. The more elevated your blood sugar is, the more insulin you release. That blood sugar causes inflammation, causes insulin resistance. The body fights that insulin a little bit, causes more insulin to be produced. That causes weight gain. Insulin is what we call an anabolic hormone. It actually stores sugar, so it actually promotes obesity. So it can really be problematic if this kind of perpetuates over and over and over again for years. Insulin is essentially toxic in many ways to really promote that blood sugar being put into the cells, which actually, again, promotes obesity in many ways. Next slide, please. So how do we affect treatment? How do we treat diabetes? How do we treat the obesity? Focus on diet. Really, that's the fundamental number one, number two, and number three, in my opinion. Eat less, usually around 100 grams of carbohydrates. If you look at the recommended daily allowance, they usually say around 300 for an average 2,000 calories a day. And I think that's way too much, particularly with the predominant carbohydrates we get in America, the bread, rice, pasta. Really focusing on good quality carbohydrates, things like a lot of vegetables, some fruits, again, some nuts, the more seeds, things like quinoa and millet, buckwheat, farro, these more kind of older grains and seeds that actually have been very effective. They actually have a much better effect on the blood sugar than the white bread and the white rice and white pasta. Exercise, all activity counts. So walking to the car, taking the stairs, don't take the elevator, using the bike, using the pool, yoga, chair exercises for some of us that have some limitations in terms of ability to be really active. There's so many different exercises you can do. All of it helps. I think weight training is really a wonderful way to help build muscle mass, which again helps burn calories and burn sugar. You can get into programs now, group class, silver sneakers, CrossFit. There's so many different ways to be active nowadays. And then we can accommodate and adjust those exercises to everybody's needs and different limitations and things like that. Because we all have some limitations. We can adjust those in so many different ways with keeping that intensity level high and really helping to positively affect muscle mass and weight for the whole body, not just walking is great. It's simple. It's an easy exercise, but there's some of us that's a little challenging, particularly for some of the knee arthritis and hip arthritis. So trying some of these upper body activities, which do have a positive effect on the weight and the body weight, it really can be great. Medications, as we talked about, there's some supplements that, with some guidance, can be appropriate. Humana sylvestre, cinnamon, alpha lipoic acid, chromium picolinate. There's been some small studies showing that these can have a positive effect. And always, of course, when you start an exercise program, particularly if you have a number of different health issues, you always want to talk to your physician, either us or your primary care physician, to make sure it's appropriate to get started in a good exercise routine. Next slide, routine. Next slide. So this is kind of a summation of that, frequency, intensity, time, and type, what we call FIT. This is related to exercise. So you want to try and do several sessions a week, minimum of 2 to 3, really trying to be active 5, 6, 7 days a week, being active. Remember, all activity helps. So even doing the chores and the yard work, that all adds into your physical activity, particularly when you're able to get that intensity up to 40 to 50% or 60 to 70%, the more moderate to high intensity levels. At times, interval training can be really, really effective to help improve strength, muscle mass, and reduce your risk of cardiovascular disease and heart disease and diabetes and obesity. You don't have to do it all at once. You can 30 minutes to an hour a day. You could do small sessions, 10 to 20 minutes. It does not have to be all at once. You can do what we call interval training, where you maybe train at a higher level for a minute or 30 seconds, and then go at a lower level, minute at that lower level, and then go back to the higher intensity. So you do not have to be at a high intensity the whole time. Type of training, things like weight resistant training, weight training, free weights, but again, yoga, body weight training. Obviously cardiovascular activity, even stretching. All of this can even help balance and help reduce risk of falling, which can be common in some of the arthritic patients. So all of this can be very effective, kind of getting a well-balanced program to help keep things at bay and keep things under control. Next slide, please. So osteoarthritis treatment. This is, pretty much what we do in our office on a regular basis. Lifestyle modifications, minimize activities that aggravate conditions. So there are different things that we can do to, activity helps, but some activities may be challenging for you. So can we make some adjustments to keep you active, but keep you active safely? Switching from, high impact exercises, sometimes jogging or tennis, maybe singles tennis to doubles tennis, to lower impact activities, swimming, cycling, yoga, activities that can help improve balance, Tai Chi, some isometric exercises can be very helpful and very easy on the joints. Like we talked about weight loss. We talked about the stress on the joints with the added pound, that it really is significant. Physical therapy. Some specific exercises, again, can help on hip, core, pelvic, knee strength and balance, and help reduce pain and help increase function. Heat, ice, pain relieving ointments, creams, CBD oil now is popular, that may have some benefit. Diclofenac, which is an anti-inflammatory cream that's over the counter now. That can be a nice adjunct, which is relatively safe for most of us. Sometimes the assistive devices, canes, shoe inserts, braces, unloading knee brace, which is a special knee brace that we can recommend. Next slide, please. And then you get into the interventions. When appropriate, medications such as Tylenol, anti-inflammatories, ibuprofen, naproxen, or Celebrex, which is a COX-2 inhibitor, which is a little variation on those type of drugs. You have to be careful for these, even over the counter. They can hurt the heart, they can hurt the stomach, cause stomach bleeding, they can affect the kidneys. In some cases, oral prednisone, as Dr. Tigges spoke about some of the lupus and rheumatoid arthritis. Sometimes prednisone can be a mainstay in some of the treatment for those type medications. Sometimes in short term, it can be appropriate. We try not to use it long term because it has a lot of negative effect on the bone, but short term can be appropriate. Supplements, two main supplements. There's many out there, MSM, but glucosamine and chondroitin. And turmeric. Glucosamine, chondroitin can maybe help some of the joint, lubricate the joint a little bit maybe. The turmeric is an excellent anti-inflammatory from a natural perspective, a very low side effect profile. So that's a really nice adjunct supplement that we often use, and it actually, patients get pretty good results with that. So that's nice. The steroids, again, oral and injections. So intra-articular means a joint injection, a steroid injection, which is a common treatment that we do. Usually 3 to 4 months. It can help reduce inflammation and pain. Repeated injections can sometimes degrade the joint a little bit and worsen some of the arthritis over the long haul. The gel injections or the visco supplementation, those are the series of 3 or 5 injections, which can be very nice to help have 6+ months of improvement in pain and function. Some of our partners do things like PRP or platelet-rich plasma or stem cell, which are regenerative medicine options, which have had some good results, again, with more restorative, regenerative to the cartilage, which is a still growing area. Those aren't covered by insurance, but they are really nice options. Things like the acupuncture, dual wave laser, and then the joint replacement, as Dr. Tigges spoke about earlier. Next slide, please. So this just kind of goes into some of the different treatments. This is the AAOS, is the Major Orthopedic Society, and the VA is the Veteran Affairs group, but really kind of focusing on what we just described or just talked about. Some other medications do loxetine or tramadol, maybe a little bit, maybe okay from a pain management perspective, and maybe a little bit safe in terms of some of the risks with the anti-inflammatories. I don't use capsaicin much. It burns most people's skin. But again, the number one thing that most people talk about is the weight loss and the exercise. Next slide, please. So this is a little bit more on the supplements, curcumin or the turmeric, the glucosamine, some recommended dosing, MSM, as I spoke about. Fish oil can reduce inflammation. Vitamin D can maybe help reduce risk of injury. Some of the lower ones, some smaller evidence for those, but collagen, boswellia, which is another anti-inflammatory, and then some antioxidants such as picognagol and the vitamin E and selenium. Next slide, please. So back to you, Russ.
These pictures must mean it's my turn again. That was great, Karl. Really, really great information. And, we're going to emphasize it again after I get done talking about my fancy pictures. But it's amazing how important the non-operative, the medical, and the basic treatment of these diseases can be before you get to this crazy stuff I'm showing you here. In the middle, there's that darn x-ray of the knee. You can see where that blue arrow is, that's bone on bone. So that person needs a knee replacement to get it cured. And the picture on the right there shows a partial knee replacement. You see we shaved out the arthritis and we put a piece of plastic in between the two metal pieces to recreate that space between the two bones. And that's what a knee replacement looks like after it's all said and done, or at least a partial replacement. Full knee replacements, you just take that part of the knee and expand it to the other side, and it includes both sides. The picture on the left is a really nice picture of a hip replacement. You can imagine, you see the ball there sitting inside the metal socket. So we just cut the bony ball out of there, the ball joint of the hip, and we replaced it with that metal ball. We got to hold it there somehow. We attach it to that metal stem that sits inside the thigh bone, nice and tight. That stem is made out of titanium. The ball is almost always made out of ceramic. The cup sits inside the pelvis. Sometimes we put that screw in, sometimes we don't. That cup is made out of titanium. You can't see it, but there's a piece of plastic between the ball and that metal cup. And that plastic allows everything to move nice and smooth. So those are the cool pictures. Next slide. Joint replacement, very successful. Gosh almighty, I wish I could get one almost. There's many studies that are done, and there's actually a really cool study that was done a couple years ago. Total hip replacement, according to Medicare evaluation, is the most successful surgery in the United States as far as getting people out of pain and back to being participating and productive in society. I think almost anybody you talk to who's had a hip replacement would agree with that. It can take you from the sidelines to the game very nicely. But there's risks. There's risks to everything we do in medicine, and especially in surgery. They're small, but they're still present. There's always a risk of blood clots. We use blood thinners and horribly uncomfortable stockings afterwards. There's always a risk of infection, no matter how hard we scrub our hands and scrub our toes and use antibiotics. There's still always that small risk. And of course, there's medical complications. Some stuff you just can't control. We usually blame it on anesthesia, but honestly, it's usually some underlying medical complication like a heart attack, or sometimes you get pneumonia. And guess what? Each one of these complications right there have a higher chance of happening if you're obese or if you have any type of diabetes. If you have a BMI greater than 40 on that one slide, the reason the insurance companies don't want you to have surgery is because you have a 7 to 10 times higher risk of getting one of these complications if you have a BMI above 40. You have a 3 to 5 times higher risk if you have a BMI over 35. You only start getting down closer to normal if your BMI is under 35. So why would you take those risks if there's a way to get your BMI down? In other words, if you can take control with nutrition and exercise of any sort and try and get the obesity better, or maybe even get rid of your type 2 diabetes. Yes, get rid of your type 2 diabetes, which is very possible. if you can get the obesity down and get the sugar levels under control. Next slide. So a nice quick conclusion. Eat right, get active. Sounds pretty simple, but we all know it's not. We're not sitting here, shaming anybody. We know it's not easy. We know it's a daily trial to do a lot of this stuff. But I hope, as you saw with Karl's presentation, it really is so important to get the weight as low as possible and to get the diabetes as under control as possible. We have the opportunity to get you off of all your medicines in type 2 diabetes. Maybe not everybody, but most people who have type 2 diabetes, if they can control their diet, minimize their carbs, get a little bit of exercise, almost all of them can get off insulin and even get off their pills. Multiple studies have shown that. And that can markedly decrease your risk of any type of surgery with the joint replacements. He talked about the alternative medications. We're big fans of those. He mentioned the turmeric and curcumin. There's many treatment options. I like the fish oil a lot. The glucosamine is a decent, safe option, although it can raise your glucose levels if you're diabetic. All those things are pretty well tolerated. As I said in the beginning, there is a chat box that you're welcome to type some questions into. There's a Q&A button that you're welcome to type questions into. I think we got one question and I think we answered that pretty well. So start typing away, and I'm going to go to the next slide. Just remember, arthritis never gets better. Not yet. I'm going to come back to that. But it always gets worse so far. I do think there's, some very promising research being done on stem cells. Karl had mentioned that a little bit. We're not there yet. I think most stories you hear about the miracle of their stem cell injection is probably mostly placebo and partially cortisone effect like. But I think there's a lot more stuff to come. I just don't know whether it's 10 or 20 years from now. So when you get your arthritis treated, especially with me, let's try and minimize those risks. I think that's what's very important. Next slide.
And we have a couple questions. I think I can answer a couple
Go
of
ahead.
them.
Go ahead.
So I think one was with respect to, it's scanned down, but one was a gentleman that had type 2 diabetes, heart disease. He was on Ozempic and metformin, and he had some weakness in his legs. I think he had bilateral knee replacement. So yeah, that's a very common situation. Those are good medications. I think the SGLT2 inhibitors are nice options as well. With respect to the weakness in the legs, I do think combination training is really, really important. I think strength training, sometimes group classes, one-on-one training with, again, a physical therapist or a personal trainer can be quite effective to kind of come up with alternative exercises to focus on hip and knee strength. And I think that could be really, really effective to help get that strength and kind of work on the whole body as opposed to just the walking. And then I think there was a question regarding the gel injections. There's really not a ton of side effects, right, Dr. Tigges, with respect to the gel injections. Yeah, obviously,
go ahead.
Infection. I'm sorry, go ahead.
No, go ahead.
But the side effects are really quite good. They really do work. Some insurances, as they alluded to, some of the private insurance companies don't cover. Medicare does. Some pick and choose which ones they cover, but the really side effect profile is pretty good.
Yeah, they are. Karl, I got one here. Best dosage for the turmeric or curcumin?
I think, usually 180 to 400 milligrams.
Somebody asked about hip shoulder arthritis. I'm not going to go into that, but basically, I don't do shoulders. Basically, the treatment for shoulder arthritis is roughly the same. We have a couple of great shoulder surgeons, Dr. Kuzier, Dr. Coleman, Dr. Maurer, all do shoulders, who are very good at that. Is it true damp weather aggravates arthritis? Well, it's sort of true. We do know that changes in the barometric pressure definitely affect inflammation. And so if you have scar tissue or inflammation in a joint, it's the change in the barometric pressure that actually affects the arthritis. Karl, anything to add on that?
No, I think, yeah, it's pretty much, it's very common, as the weather changes, you do see a lot of patients coming in because their pain is increased. Just from a quick perspective, there's a couple questions on arthritis in the hands, similar to the shoulder conversation, very similar conversations in terms of medications. Corticosteroid injections can be really effective for those. I did a number of myself this week. They're really quite effective.
Let's see what's here. Somebody was asking.
And with respect to gout, supplements would be the same as the arthritis supplements. The fish oil, really modifying that diet a little bit, and then some medications, a little bit different than what we talked about, colchicine and things like that, can be effective for the gout.
Yep. Here's a guy who's had both hips replaced. He goes for walks. He has some cardiac disease and he's diabetic, but he feels like his knees are weak. How can he strengthen them? Well, I mean, one of the easier ways, I think, is an exercise bike. Swimming, treading water takes the weight off. Physical therapy to show you some specific exercises would probably be very beneficial. And then he's asking about Ozempic and metformin as a good treatment for diabetes. Karl, you got an opinion?
Yeah, I think that's a good regimen. I think, the GLP-1 analogs, the Byetta, Bydureon, Ozempic, and, the SGLT intuitive, those are the best medications from a heart perspective. They really show good data. And the metformin is a pretty standard medication that's inexpensive and works very well to help modify that diabetes. I think that's a good regimen, assuming that diabetes is well controlled, but really focusing on that diet.
Good. Why don't insurance companies pay for the gel shots? Well, Medicare does, and to be very honest, there's, even in the best studies, it helps about 80% of people with knee arthritis. In a couple studies, actually more than a couple, it shows that it might not even be better than placebo. And so for that reason, and they're very expensive. A single shot costs several $100s or over $100, depending on which brand you use. And so a full series of treatments can be anywhere from $500 to a couple $1,000s. And, the insurance companies are trying to cut money. Even if it helps 60 to 80% of people, placebo effect or not, they're going to cut money if there's no definitive evidence.
There's a couple questions. So one, this one I think is a good one for the type 1 diabetic with a BMI of 19, having it, do they have an increased risk of joint replacement? And I'll take this from two different perspectives. So if you have chronic type 1 diabetes that's well controlled and you've had it for many years, most studies show that you really do not have a significant increased risk of the complications related to diabetes. With respect to joint replacement, I don't think you have any higher risk than the normal population, not dramatically higher risk than a normal population, particularly with a BMI that's well controlled like 19. So no, I do not think that is significantly bad for you in terms of osteoarthritis, except if you had really poor control of the diabetes. If the diabetes was not well controlled, that would be bad. A couple questions regarding the type 2 diabetes in terms of urinating at night and things like that. Depending on what the blood sugars are at night, you check that. Obviously, there could be other reasons why you may have to urinate a little bit in terms of prostates and bladder issues and things. But with respect to the medication, usually we'd stay on metformin and add those other medications such as Jardiance or Byetta or Bydureon.
Couple questions on supplements again. Let's see ones here. Arthritis never gets better. What does taking the supplements help then? Well, the supplements in general, there's two basic reasons to take the supplements. Number one, decrease inflammation, both for your joint and in general. That's the turmeric, that's the MSM. Fish oil and glucosamine, in theory, help feed the cartilage that you have. So it tries to keep the cartilage that you still have as healthy as possible. But then a couple of the other supplements work more for inflammation, to help decrease inflammation. So then once I've had knee replacements, no need to take the supplements, right? Well, correct for your knees. If you got a back, hips, shoulders, hands, it doesn't specifically only work for the knees. But yeah, if you're feeling good, don't take it.
And again, a couple questions about other joints. Yeah, I treat pretty much every joint with respect to arthritis. The curcumin and turmeric is just different variations. They're essentially the same product. The increased risk of blood clot and knee replacement. If you had one with meniscal surgery, Dr. Tigges, I mean, to me, that's an increased risk, post-operatively.
Yeah, once you've had a blood clot before, you're at increased risk to have one again.
Yeah.
Here's a great one.
Okay.
I'm sorry. Go ahead, Karl. Finish up.
I'm sorry. So sometimes we would do prophylactic medications for that. Doing like the Xarelto after surgery just to help prevent it, but the risk is definitely high.
I had this question here. I couldn't resist it. I have trouble getting out of a chair after sitting a while. Is that a sign my hips are going bad? After I'm up, my hips feel better. That's not a sign of your hips. That's your sign of getting old. But it might not just be your hips. It might be a sign, I laugh about it, but it's true. As we get older, our muscles get less strong, which makes some normal activities you used to do tougher. And so my answer isn't so much, whoa, what's going on with the hips? My answers would be, whoa, what's going on with your strength, your overall muscular strength? Maybe we need to do a conditioning program, work a little bit harder on some exercise, maybe do some formalized physical therapy to get a little more better active. And I bet that would make a big difference with that.
I think this is a good question with respect to weight loss surgery. Either with or without knee injuries or prior or to, I think in the right situations, weight loss surgery can be an option. I think there's a number of different weight loss surgeries now. I think in good hands, there's a good group in the Poughkeepsie area doing the weight loss surgery. I think in right hands with the right group, if you go through that process, and it is really a long process to do weight loss surgery, that can be effective prior to knee and hip replacement. You still may need the knee and hip replacement, but it certainly, as Dr. Tigges alluded to, it will help with the complication risk and maybe push off that surgery down the road, which can be very helpful in many ways.
Any benefit from drinking bone broth? Well, bone broth has the collagen in it. It also has a little bit of protein in it. And so from a supplement standpoint, bone broth's getting a lot of good press lately. I see no downside to it. I think it's a nice option to help with inflammation. Couple questions about the laser treatment. The laser treatment's really interesting. We know it works great for inflammation, tendinitis, and there's also some nice studies that shows it can help decrease the inflammation in arthritis. It's not covered by insurance, so it's a little more expensive than a regular office visit. It does not cure arthritis, but it definitely can help with the inflammation. So it might be something to consider if you're looking at all options and nothing seems to be working, but it's not going to cure your arthritis.
Well, the one question, does arthritis spread to other parts of the body? No, it doesn't spread, but just from, as Dr. Tigges alluded to earlier, the genetic concept, genetically, some of us are more predisposed to it. Injuries, to any part of the body can increase risk of arthritis. So it's not so much that it spreads, it just, or unfortunately, many of us have it in multiple joints and do need treatments in both knees, both hips, the hands. The thumb is a very common area for arthritis. I do injections for those and different treatments for those. But overall, it's the same kind of overall process and treatment protocol with respect to the hands, except for the weight-bearing activity.
If you have a hip replacement, would being overweight cause the longevity of the replacement to suffer? The answer is maybe. Morbid obesity definitely decreases the life of especially knee replacements, but also hip replacements a little. BMIs greater than 40 really cut down the longevity. A good hip replacement should last 20, 30 years at least. If you're got a BMI greater than 40, it's not going to last that long. Knee replacements, literally the length of a knee replacement's cut in half or more if your BMI is over 35.
One comment regarding the prednisone and arthritis. So some people have to take prednisone for rheumatoid arthritis and a variety of rheumatoid conditions, and that will increase your blood sugar. Interestingly, with the prednisone or steroids, so even the steroid injections will increase it for about a week or so. Prednisone will have a really problematic effect on your blood sugar, what we call postprandial. So not so much the fasting blood sugar. So in many cases, almost the fasting sugar could be normal, but it's that food. When you eat, you'll even have a greater response to your that food with your blood sugar. So one of the big things is really looking at that diet, looking at exercise, looking at activity to counteract that as best as possible. Because that person that's on prednisone that eats a small amount of sugar will have a greater effect on their blood sugar in terms of making it increase. So that could be really bad.
Somebody's asking if their hip replacement's 20 years old, do you have to worry about it wearing out? If it feels good, don't worry. 20 years in there, I'd get it checked just for a routine check, get an x-ray. Sometimes you can see it wearing out. I've seen people I've done 20 years ago and they come in, it looks like the day after we did it. And hallelujah, high fives. I probably won't ever see them again. But at 20 years, it's probably worth a little visit. Come on in and say hi, get an x-ray, and that'll alleviate anything you're worrying about.
Couple of questions regarding diabetes and an A1C. So, one question was A1C below 6% or 5.9%. Could you get off medications? And in medication, in many ways, if you maintain that, usually we kind of will slowly decrease the medications. But yeah, absolutely, you can come off medications in some cases. Sometimes people, doctors will keep you on the metformin from a almost preventive perspective, and maybe there's some evidence for that. But yeah, you can, if you continue to maintain that blood sugar, you can absolutely come off the medications. With respect to Farxiga and a blood sugar around of 130, does that equate to an A1C 7.2? Well, there's a couple concerns with that. Well, it depends on the variation of blood sugars, because theoretically you could have a lot of highs and a lot of lows, and it'll average out well. So there's you can't just say that, but A1C blood sugar is less than 130 on metformin or Janumet is fine. The Janumet is a combination medication, Januvia and metformin. So what that doctor did was switch you from metformin by itself to add in another medication, Januvia, which is an okay medication for blood sugar. It doesn't have the most effect on blood sugar as some of the other medications I mentioned earlier.
Couple questions in general about arthritis and osteopenia. I'll toot Karl's horn here a little bit. He's really an expert on treating osteopenia and osteoporosis. I'm going to let him weigh in after me. In general, osteoarthritis and osteopenia are two completely different things. It really does not affect the surgery for the hip or the knee. If you have osteoporosis or osteopenia, you know, if you're literally 100 years old and if I touch your bone, it might disintegrate. It might change my surgery maybe once I get in there. But I honestly think I might have done that once in 23 years. And I see a lot of older people. So in general, it doesn't affect the arthritis or the surgery at all. You want to comment about the medications for osteopenia possibly affecting arthritis?
Yeah, I don't think that, so none of the medications really affect the arthritis. The bisphosphonates, Prolia, maybe Forteo and Tymlos can sometimes cause more pain. Sometimes that aggravates some of the joint pain. You know, as Dr. Tigges said, you know, in certain situations, more with the spine surgery, you know, maybe we'll utilize medications before surgery and things like that, but I'm not often doing that, you know, at the request of the knee replacement surgeon or anything like that. They're usually kind of two separate things, the osteoporosis and the osteoarthritis. The only similarity is more that they tendency to affect us when we're older. So. And going back to one of the best treatments would be exercise and a good healthy diet. So, you know, early on, really building up that strength, building up those bones with weight-bearing activity.
Somebody's asking about bilateral surgeries. Good question. I mean, we see a lot of people with that. Both knees are bad, both hips are bad. In general, we do one side at a time. The days we used to do both knees at the same time. I've done both hips at the same time. The problems with that is that it definitely, we know that increases the risks. You definitely lose more blood. There's a much higher risk of getting a blood transfusion. Believe it or not, it raises the risk of getting a blood clot in the legs, probably because it's just that much more stress. And it actually, for the most part, does not raise the risk of infection, but it does raise a significant risk of cardiovascular event, like a heart attack, just because it's so much more stressful on the body than having one and done at a time. If you do one at a time for a healthy person, we consider doing the second side 4 to 5 weeks later. If you're not exactly perfectly healthy, we usually try and wait anywhere from 6 weeks to 3 months. Oh, what do you think? Heat or ice? That's a, I'll let my sports medicine guy talk about that a little bit.
So yeah, so there's a little controversy with respect to that. You know, I think, you know, if you have a swollen joint, you know, that knee is a little swollen, it's a little painful at the end of the day, I think ice can be very effective for that. I think you can overdo it on ice, you can burn yourself on ice. But, you know, I think ice will be helpful for that. Some of the more muscular issues, heat, I do think, as Dr. Tigges alluded to, some people talked about, they do better as they get moving a little bit. So I think that implies the warmth. Heat seems to help people a little bit better, kind of mobilize a little bit. So I think heat is better, kind of getting things going and kind of warming up those joints, so to speak.
If you have any questions, we're trying to scroll through these a little bit. If you type it in again, we're at the bottom of the list. Happy to answer. Any difference with arthritis in the spine? You know, for the supplements and stuff, there's really no difference. I think the supplements are basically the same type of activity. You know, the injections, there are cortisone injections for spinal arthritis. They actually work quite well. And I can tell you, if and when my back arthritis starts acting up, that's where I'm going to go after my diet and exercise have maxed out. There are no lubricant or viscosupplementation shots for the spine as of now. But again, you know, the basic treatment is the nutrition and good activity, keeping your core, your stomach, and your back and your pelvis muscles as strong as possible is really the key for spinal arthritis. Is there something you can do with meniscus and possible replacements? So in general, in the knee, the meniscus, somebody having a torn meniscus is really something, it's a condition that's not really part of the discussion for replacement. Replacements are used for loss of cartilage that covers the bone. We do call meniscus cartilage, but it's not the cartilage that you lose for arthritis. You can take a 20-year-old person, cut out their entire meniscus, and technically they do not have any arthritis. They still have all their cartilage covering their bones. And so they're two different conditions. So in general, if you have a meniscus tear with bad arthritis, getting rid of the meniscus tear isn't going to help. And we've proven that over and over. And so probably the answer is a replacement. If you have a meniscus tear with either no or very little arthritis, then getting the meniscus treated may be the best option for you to avoid a possible replacement.
And then, you know, one question regarding that diclofenac cream. I like the diclofenac cream. I use it for some patients that have some reasons why they can't take oral medications or they shouldn't be on it a lot. So I use the anti-inflammatory creams. I use it for some of the hand arthritis, from the knee arthritis. Again, it's over the counter a little bit now. So I use it. You know, is it great? You know, in terms of tremendous benefit, not always, but you know, I think it's a relatively safe medication that can be helpful. Just one thing regarding very low blood sugars. Well, the concern with low blood sugars is you know, like death and you know, and passing out and being unconscious and falling. So very low blood sugars are concerned from a falling perspective, not so much from a direct arthritis pain or anything, but from, you know, low blood sugars are bad. So that goes into that kind of variation in the blood sugar that I was talking about earlier. If you have a lot of low blood sugars, that can be almost as bad in different ways, if not worse. Sometimes we're actually more fearful of the low blood sugar than the high blood sugar, particularly acutely.
All right, Judith, go ahead. Ask us a question.
I'm an 82-year-old woman, and I used to be 5'2" or so, 5'1½", and I'm now 4'10½". And the arithmetic to figure out my BMI is too hard for me, so I thought I'd ask you.
How much do you weigh?
I weigh 132.
You're fine. I don't know what your BMI is, but you're fine.
Okay, that's what I wanted to hear. Thank you for satisfying me.
You're welcome.
You're welcome.
We got a question here about upper age limits for knee replacements. Essentially none. I've done hip and knee replacements on people over 100 years old. I've done them on patients in their 20s for car accidents and severe rheumatoid arthritis. You treat what the disease is with what needs to be done. Obviously, if you're too old to function other than your knee, then it would be a waste of time to do the knee replacement. But if you're otherwise healthy, let's go.
And yes, pretty much, I think there was one question regarding kind of with the current viral issue, are we in the office and things like that. Pretty much all of us are in the office, I believe, and physical therapy is available as well. So Charmaine, should we?
Yeah.
Oh, yeah, go ahead.
Hi, Dr. Tigges.
Hello.
Hi. Post-knee replacement. If you have a lot of scar tissue, a lot of pain, if you have your scar tissue removed, is there a possibility that it can come back again, the scar tissue?
Simple answer is yes. Everybody after any type of surgery gets a little bit of scar tissue. Some people are more prone to getting excessive scar tissue, especially in knees. I mean, it's not common, but it's not rare for people to get some scar tissue in the knees. In general, if you open it up and cut it all out, it just grows right back. Now, if you go into a knee replacement with little poke holes and clean it out arthroscopically, it has about a 90 to 95% chance of taking care of your symptoms. I've seen a few people grow the scar tissue back, but it's more on the 5% range. So it's usually a very good trusted treatment.
Thank you.
Yep. So recovery time for a knee replacement if you have diabetes. So that's actually a good question. If your diabetes is well controlled, your recovery is, I'll call, pretty normal. So that means hospital for either maybe straight home, maybe a night or two in the hospital, a cane for anywhere from 2 to 4 weeks, physical therapy for a month. Everybody continues to improve for a full year, feeling better, getting stronger, but you get about 80% of your recovery in the first couple months. Now, if your diabetes is under well control, A1C, let's say in the 6s, you'll follow that path. If you're not someone who's agreeing with our presentation, and your A1C is 7.8, shame on you, you're going to have problems. You're going to have stiffness in your knee. You're going to have extra swelling. You may require more surgery to get the stiffness out of your knee. You have a marked increased risk for infection, inflammation, drainage. We can just go on and on. So it really does depend on how well you control your diabetes. It's up to you. Recovery time for meniscus surgery. It can vary in general. Most people feel pretty good pretty quickly. Getting back to normal activity is a tough answer. Most people are doing most activity within a week or two, but to feel perfectly normal, full strength, it's probably closer anywhere to 2 to 4 months. I've had my knee surgery done and I was back in the gym in a week and a half. I didn't feel normal for over 3 months, but I eventually did. But it just takes that long to feel strong. You got to remember, even the professional athletes who get a meniscus surgery, they're out, 6 weeks, and they got a trainer and a therapist literally sleeping and living with them. So it just takes a while.
I wanted to take one question regarding, isn't it dangerous to come into the offices during quarantine? And I would say, really from, to kind of talk about our office specifically, I don't think so. I don't think it is dangerous. I think we really have been proactive from early on to be as safe as possible. We screen from a temperature perspective. We limit the amount of people in the office. We do not have the chairs set up the same way, so you can't sit. You have to have some social distancing within the office. We've really done a good job, I think, about being proactive with keeping people safe in our office, minimizing exposures, minimizing time in the office. Again, the masks, hand washing, gloves for us. So I think it is about as safe as it can be, with respect to coming to our office, and I think we're doing a good job with that.
So I think go ahead, Karl.
No, I'm good, Russ.
So I think at this point we're going to wrap it up. I got a fun and kind of serious thought at the end here. That was a great response. I do think we're doing as good a job as anybody trying to keep everybody safe. Everybody's worried about the pandemic, and I was looking at this talk tonight, and the real pandemic isn't the COVID. Yeah, it's out there, but guess what? 90% of people who end up in the ICU with COVID have obesity or underlying cardiovascular disease. Amazing. Our pandemic is obesity and type 2 diabetes. It's not the COVID. So if you want to try and be healthy, get healthy and stay healthy around this new virus. But hey, we got a much worse pandemic out in the world here. We've got millions of people. 60% of the population in the United States That's almost 200 million people in the United States have obesity. That's a pandemic. So with that, I'm going to say let's do well with our treatment options, including getting your nutrition under control, work on your diabetes to optimize it. If you need some help with your arthritis, give me or call Karl or anyone in the orthopedic office a call, and we'll be glad to see you and help you in any way we can. If you're looking for nutrition help, you're welcome to ask your primary care physician. You can ask me or Karl. We have some friends who do nutrition coaching. It's a company where they can do one-on-one coaching and can help you figure out what foods can work best for you and how to try and get headed in the right direction. We'd be glad to share that information with you. Karl, anything to add?
No, I think you did a great job with that. I think, as you said, and that obesity issue, that's not going away anytime soon. There's no seasonal thing with that. That's here for the duration. So we really have to be proactive with getting that under control. And then, like you said, those numbers are pretty staggering. So we're here for you to help in any way you can, as I'm sure your primary care providers and the other doctors and medical providers that you work with. But you have questions, ask them, and we'll hopefully do the best to get the care that you need. Thank you again.
Great. Have a good night, guys. Take care.
Take care.